wade you in. Could I call upon Dr. Neeraj Bhutani to please take over?
Good morning, everyone, and thank you, Dr. Ranjan. I would be talking about pre-thrombolysis workup. And as we all understand that the aim of pre-thrombolysis workup is to select the patients who are likely to benefit from IV thrombolysis, and then to assess their safety issues, that whether it is safe to administer IV thrombolysis or other revascularization through MT in them or not, and then to take cognizance of some special clinical situation, because every patient is different, so he may be having some special clinical situations. Then to take consent also, so we have to initiate consent process immediately, because patients take a lot of time in giving consent, and to do this in a minimum possible time, because we don't want a very long door to needle time. So this is our aims, and to fulfill these aims, these are the tools available to us. So first is clinical history and examination, the age-old tool. Then in our emergency, we have a lot of checklist protocols, and then we have to get certain lab values. So checklist mainly contains the patients where you should rule out absolute contraindications or look for relative contraindication. Protocols are there to check eligibility, and we need certain basic lab values before going for thrombolysis. And then, of course, we have imaging, and we can divide it into three parts. That is our base image or image of brain parenchyma, then image of brain vasculature, that is angio, and then we have certain special imaging tools like rapid software, which are not available everywhere. So coming to the first tool, that is clinical history and examination. So first you have to establish the diagnosis of stroke, as stressed upon by Dr. Ranjan. And once you establish the diagnosis of stroke by clinical history and examination, you have to classify the stroke into a known onset stroke and an unknown onset stroke. So most of the strokes are known onset, and you note down the exact duration, but at least 20% of the strokes may be of unknown onset. So you should note down that this stroke is of unknown onset. And then you have to assess the severity through NIHSS, that is a 42-point scale Dr. Ranjan has already shown. And then you take note of any special clinical situations if present, like a recent MI, recent stroke, or a terminal illness, or a recent surgery. So these you have to take note of. Simultaneously with clinical history, you should initiate the checklist. So I am taking these tools one by one, but these tools have to be initiated simultaneously to save time. So while you are taking clinical history, doing examination, your technician can draw blood, or someone can run through the checklist. So these things can be done parallelly, and you save time. So the basic labs which are required are ABG, electrolytes, sugar, platelet, and INR. These are the basic labs parameter which you need. And then you have to run through the checklist to rule out absolute contraindication. So you do remember that there is a change in status of many of these contraindications. Many absolute contraindications have become relative, or now no more contraindications, because we want to give benefit of revascularization to maximum patients. So I'm just giving you some examples of what changes in the checklist has happened over last decade or so. So earlier, if you have a MI within 3 months of the stroke, it was an absolute contraindication because there was a risk of ventricular rupture if you administer IV thrombolysis. Now, absolute contraindication has been reduced to 2 weeks. And from 2 weeks to 3 months, there is a relative contraindication if there is an STEMI MI, and non-STEMI MI, there is no contraindication. Similarly, hyperglycemia more than 400 used to be an absolute contraindication. Now it is a relative contraindication. We know that the outcomes are not as good in patients with hyperglycemia, and bleeding tendency is slightly more, but still it is not an absolute now. Dual antiplatelet, you can do IV thrombolysis. See, minor strokes, usually it was recommended that you should not do IV thrombolysis, but now in certain situations you can do. Seizure at the onset of a stroke was an absolute contraindication. Now it is not. Stroke within 3 months was an absolute contraindication. Now it is not. And old ICH was an absolute contraindication, but now if the ICH is very old, like more than 2-3 years, and small ICH, you can still do. So these are the changes we should take notice of. And then the next step is imaging of brain parenchyma, which also you have to do simultaneously. And we have two imaging tools available commonly. One is CT scan and another one is MRI. So thrombolysis is essentially CT based, and it is the investigation of choice because the ease of doing it, it is less time consuming, it is so widely available, and can be performed in irritable patients also, and patients who are non-cooperative. And our main aim is to rule out ICH, which CT can do easily. Now, MRI is preferred in certain situations. Firstly, when diagnosis of stroke is uncertain and you are not sure whether it is a stroke or a stroke mimic, you may prefer MRI because it gives a better idea. Secondly, when the duration of stroke is uncertain, like a wake-up stroke, then MRI is the investigation of choice because as per wake-up trial, you have to look for a diffusion and flare mismatch that infarct has appeared in diffusion but not in flare. And sometimes some neurologists do prefer MRI at the brink of window period in severe strokes because they want to see whether already flare and diffusion changes have appeared and should they thrombolize or rule out these patients. And with the brain parenchymal imaging, immediately you have to do angio. Angio is must for all, and CT angio is preferred over MR angio by most. And the only issue is that when you are choosing MRI as your base imaging, then probably you have to go for MR angio only because shifting the patient to another machine is not possible. But in many centers, if both the machines are in adjacent room, people are doing MRI and then shift the patient to CT angio. So the aim of doing the imaging is to identify the vessel involved. So if there is a large vessel occlusion, you know that the recanalization with IV thrombolysis is only 14-15%. So you have to alert your mechanical thrombectomy team that this patient may need MT. And then you have to assess the collaterals also, which are assessed in late arterial phase. So patients who are having good collaterals, even at the end of the window, they will be having a good viable tissue. So outcome is better. And you can study the clot characteristics also, but clot characteristic doesn't change your decision much. This is a retrospectively, you can study that what kind of clot it was, hard or soft or something. So this is showing the collaterals. So from no collaterals to good collaterals, as you can see. So better the collaterals, better is likely to be the outcome because more chances of viable tissue. And these special imagings are not widespread available, but if it is available, you can use it to study mismatch. The main aim of this special study imaging is to study mismatch beyond 4.5 hours, so you can extend your window. My rapid software is there, which was used in extend trial and diffuse trial for IVT and MT, and then you have CT perfusion and MR imaging. So these are the tools which are available to you for pre-thrombolysis workup. Now, I will take some case scenarios just to exemplify that how various tools can be or various routes can be administered in the given clinical situations. So suppose a 62-year-old man presented with right side weakness and global aphasia for 4-hour duration, and CT scan is done outside, which is normal. So clinically, you may think that probably because of global large vessel occlusion in this patient. So one option you have that quickly run through the patients through your checklist, find out the eligibility, do the labs and do IV thrombolysis. Second option you have that you do CT angio because CT is already done and you offer him direct MT if there is a large vessel occlusion, or you can go for MRI brain with angio and see that how much diffusion and flare restriction is there. So in this case, probably as of now, I think you can do the IVT directly because patient is well within the window if is found eligible. And after that, you do CT angio, patient doesn't improve, alert your MT team simultaneously that this patient may need mechanical thrombolysis. Secondly, if a 62-year-old lady with left hemiparesis, grade 2/5 and intact sensorium, 1.5 hours duration. So historically, it doesn't look like a large vessel occlusion, maybe a subcortical stroke. So you have option of CT with angio, then offer IVT, MRI with angio. Obviously, you will run through the labs and checklist to find out the eligibility, then option of special imaging and consider direct MT after imaging. So this is a classical case where we will prefer CT based IV thrombolysis. Do CT with angio. Even if you find a large vessel occlusion, do IVT, and then you alert your MT team also that you are doing IVT, and if patient doesn't improve, they can consider that. This is another controversial issue when the patient has a dense hemiparesis, but by the time he reaches hospital, his hemiparesis is improved. So he has a minor non-disabling stroke. So whether to thrombolize these patients or not. So one option earlier was to just do imaging, do conservative management, find out the cause of his stroke. Now there is some guidelines, not guidelines, but recommendation from European Stroke Organization, their expert committee, that if these patients have a large vessel occlusion, you may thrombolize them even with a minor non-disabling stroke because they may progress. The fourth scenario is a typical wake-up stroke. A 50-year-old lady wakes up with left hemiparesis, left gauge palsy, and altered sensorium. So in this case also you can guess because there is a gauge palsy and altered sensorium. So it looks like a large vessel occlusion. So in this case, MRI is preferred because it's a wake-up stroke. And if there is a diffusion and flare mismatch, you can do IVT. Suppose if you don't have MRI at your center, in wake-up stroke, you can still do CT-based thrombolysis. This is recommendation of TRUST CT trial published last year, that if aspect score is more than 7, you can do CT-based thrombolysis in unknown onset of wake-up strokes also. And then if you have special imaging, you can do special imaging and apply the radiological mismatch criteria of extend and diffuse, because this patient may be a candidate of mechanical thrombectomy. Even if you don't have special imaging, you have DAWN trial, which has a clinico-radiological mismatch criteria. So this criteria can be applied and patient may be considered for MT. So this is the last patient. 63-year-old lady presented with seizures, altered sensorium, right hemiparesis. So this is her MRI. There is a large area of diffusion restriction here. And MRI was preferred because the diagnosis of stroke was not certain. Some ill health was there and patient presented with seizure. So MRI was preferred over CT. Now, if you see the diffusion images, there is nothing much is shown, but flare, nothing is shown. Diffusion is extensive restriction. And this patient has a large vessel occlusion. So this is a known onset stroke, not an unknown onset stroke, but you are getting a diffusion flare mismatch, but diffusion restricted area is quite big. So should we do something in this patient or not? I am just leaving it open for the house.